I'm just going to do a radial pulse real quick. Our normal resting heart rate's between sort of 60 and 100 BPM. Going to check that it's strong and bounding, and I'm going to check for emission. So you mind if I take a pulse?
Good.
Cheers. I'll find it. It's work till my clock comes around, so I'm bad at maths. We've got a radial pulse of 17 there, which comes to about 68, so that's good. That fits between our regular BP. So, I'm just going to do blood pressure real quick and go vitals. Looking for a systolic pressure of between 100 and 140 and a diastolic of between 60 and 90. So Alicia here is going to be my little mannequin or whatever you're called.
Patient.
So we're just going to try and remove everything out of the way of the cuff, and we're going to ask permission, if you don't mind me doing it.
Yeah, that's good.
Lovely. I got a little line on these blood pressure cuffs that we can put down the branchial. So follow that. Try and leave enough room above the elbow for my stethoscope. Lovely. And we're just going to inflate it to around 150 and go from there. I'll bring it up a bit more if it doesn't stop the pulse. Close off our stopper valve. And we'll just put that up here. Listen for the pulse. Sorry. Stop it. Yeah. And we'll just release it nice and slowly. For our systolic. And our diastolic's about 64, so your blood pressure is 134 over 64. Alright, so the last vital sign we're going to do is a rest break real quick. We're just going to look for simultaneous chest rise while we're counting our rest. Obviously words per breath, all that sort of stuff. So I'm going to go for 15 seconds on my watch, and I'm just going to count how many times Alicia breathes. Cool, so that was 4 breaths for 15 seconds, so I'll multiply that, that's 16, 4, 8, 12, 16, which is good. That falls between our normal rest break. So the other thing we're going to do, we're just going to check for sounds between the lungs. We'll check all 4 lobes on our way around, but I'll do 2 for the purposes of today. So I'm going to check for permission first. Do you mind if I listen? Breathe in. In, out, lovely. So that's nice clear sounds. If we heard a crackle or something, that could indicate water or punctures, or if we heard nothing, radio. So we're just going to do some hemorrhage control. Alicia seems to have a bit of an accident in her arm, so we'll just expose that real quick, and I'm going to put my PPE on first. And we've got a bit of a sad face here. So what we'll do real quick, just find some saline. We'll give it a little bit of a wash off. We can use it as a bit of a jet. Sorry, carpet. That'll be nice and clean enough for us for the time being. Use a nice small dressing, as small as we can get. Just going to cover it. So it's good to have a bit of extra there, especially if it's a really bad bleed. We'll come through. You don't mind me fixing the bleeding, by the way, eh?
I do not mind.
Cool, that's good. Should I check that first? stays in place for the first few rounds. And then start twisting it over top of our dressing. It just applies a bit more pressure to the localised wound, if you like. That's good, just crossing over some nice straight bones. How does that feel? Comfortable?
Good.
Lovely. We like comfortable. Just keeping that pressure on top of the wound itself. And round and round. Just like that. Here we have it. Tuck that in somewhere nicely. Oh, we have these nice little clips that we can use as well. So it's easier. Oh, bandage over it. And here we have it. So now I'm going to do an OPA. We measure an OPA by going like that from the corner of the mouth to the side of the earlobe. Indications for use are GCS below 8 and incomprehensible sounds to pain. Contraindications can be it can create a gag reflex, or there is an intact gag reflex. Now complications can be too big, too small, damage to oropharynx, or induced vomiting. But to insert, we have it upside down so the curve faces towards the top of the head. Bring it down to such a point, and then twist and send it down the rest of the way. And that's our OPA. So for our NPA, we're going to measure it from the nose to the earlobe following the angle of the mandible. So if we go around like that, we can see that this one's pretty much right for our patient here. When we're inserting an OPA, use a water-based lubricant all over the NPA. And we don't insert it upwards, we insert it following the airway. We're going to pick the largest nostril to go with. If we find an obstruction while we're putting it in, we'll choose a different airway or rotate. So you can see by rotating it, it's coming real nicely. Benefits to using our NPA: there's a less chance of inducing a gag reflex. They can be inserted into people with a high GCS score and always can be suctioned through an NPA. Our indications are a GCS less than 8, incomprehensible sounds to pain, or an OPA is inappropriate. Our contraindications can be a severe head injury such as base of skull fractures, and complications can be bleeding. So for oxygen delivery on our patients, we look for indications such as a decreased GCS, respiratory distress, shock, traumatic brain injury, smoke or toxic gas inhalation, SATs below 94%, and of course we're going to use our clinical judgment as well. So today I'm going to demonstrate using a high concentration mask. We have our O2 bottle and our regulator. Before we go to use our regulator, we're going to check our Bodoc seal, which I pulled out and checked earlier. We're going to fit it like so the prongs line up at the bottom of our pillar valve. And we're going to give it a half turn to tighten once it's been fitted up. And we're going to check that our valve is set to 0 before we turn our pillar valve on. For the purposes of this, we don't actually have any oxygen in the tank, but never mind. So our high concentration mask, we run these at 10 litres a minute. They have a high flow, high percentage of oxygen, delivering above 90%. So we're going to lay our oxygen bottle down, and for the purposes of this, because it's a dummy, it'll be set there. And we're going to hook our tubing up to our mask, ensuring no kinks are in the tube as we do it, otherwise it's going to stop our oxygen flow. So we'll take all of that apart, and we plug this into that end, and we're going to run this at 10 litres a minute. So if we turn our pillar valve on, and then we can set our regulator to 10 litres. So if we turn our pillar valve on, and then we can set our regulator to 10 litres a minute. That will inflate our bag. If we need to, we can run it at higher than that. The main thing that we're looking for is that our bag does not get deflated. So we'll fit it to the patient's face like so, around the back of the head, and we're going to ensure that there's a snug fit around the patient's face, and we can pinch our nose piece to help seal that as well. So as our oxygen bag fills up, you'll be happy in a way and getting in. So for our suction, first we're going to do is test it. But to do that, we pinch our tube, and we need to make sure that it goes up to at least 300 milligrams of mercury. By doing this, we can turn it on to full power, hold down our test button, and we can see there that we're up to 500. And as we get up, it should cut out itself. Not that it has to, because we know now that it can suction well, and it's all sealed great, and we can hear that big rush of air coming into it. So our indications for using suction is a foreign body or a fluid in the oropharynx with decreased GCS, and we're unable to maintain the patient's airway. Complications to suction can be indicated or indication of bradycardia by vagal nerve, by vagal nerve stimulation, hypoxia, aspiration, soft tissue trauma, and a laryngospasm, and it can induce vomiting, of course. So first thing we're going to do when we start suctioning is turn on our machine full power. We're going to make sure we're wearing our PPE, and we turn our patient's head laterally to the side so we can get as much out as we can. Now we're only going to insert our rigid catheter as far as we can see, which is just the oropharynx. We come out and we can block our hole with the finger. That'll create our suction, and we can come out in a circular motion, suctioning for no longer than 10 seconds, and like so, and then we can carry on ventilating. So now we're going to do a bag valve mask. Indications for bag valve mask ventilation include respiratory failure, so that's failure of ventilation and or oxygenation, and failure of inhalation. Contraindications can include complete upper airway obstruction, and is relatively contraindicated by paralysis and induction because of the increased risk of aspiration. So first we're going to test our bag valve masks. They come packed up sort of like that. There are a few different pieces. We've got our valve, we have our reservoir, we've got our bag, we have a non-return valve, a filter, and a face mask. So first we're going to test our reservoir, and to do that we'll simply put the reservoir onto this end of our bag valve, and we pump it up to check for any leaks, and that's pretty good. So now we can check our actual bag. To do that we cover up this end of our mask, and we shouldn't be able to squeeze it. If we could squeeze it, it would indicate that we have a hole or a split. And to assemble, the bag goes on the end of our bag valve. We have a filter, goes on that end, and then we have a face mask, which will sit there. So what we're going to do, I'll just pop an airway into this patient here and we will demonstrate how to use one. So our airway going in, as we can see, that way around and then spin, and down it goes. Okay, we're going to hook our bag mask up to ventilation. So we need to run oxygen at 15 litres a minute, or 15 to 25 litres a minute, to ensure that our bag stays inflated. So I'll hook that up to our built-in oxygen. Now we have that running at 15 litres a minute. Plug that in, and we see that our bag's inflating. And to do our ventilation, place over top of the patient's face like so, creating a nice solid seal. We'll tilt back, and we're going to look for chest rise with each compression. With this mannequin we don't get it, but we're tilting the head back and we're holding everything open, making sure the airway is straight. And we're going to ventilate once every 5 to 8 seconds. We're also going to check for gastric inflation, as well, just as we're ventilating. Our second person can apply cricoid pressure if need be. But yeah, it will be 1 every 5 to 8 seconds. Just like so. Our bag's staying ventilated or staying full. So Alicia here's had herself a catastrophic hemorrhage. It's bleeding away, so we've got our PPE. These will do. They're probably better than the safety glasses anyway. So for this, for our tourniquets, we put them 100mm proximal to the wound, or 10 centimetres, whether you're an engineer or not. And come up round, and we lock it in through the bottom. Alicia doesn't mind me doing this because she's bleeding to death. Shoot round that way. As tight as we can. So that's a good 100mm there. Bring it up, strap it around, and we're going to tighten the one lace up until the bleeding stops or the pulse is gone. Distal to the wound. Cool, and we lock it in. Bring it round, put our bit of Velcro back over, and we'll note down our time. Right, so we're going to look at putting a C-collar on our patient. We're going to say that they've been in an MVA, they have an altered level of consciousness, and we're going to assume because of their mechanism of injury that they've done some damage to the back of their neck. We think about the other things with the nexus rule as well as we go. So we're going to go through and measure the neck, use 4 fingers, so that's going to point towards this patient as a large or a long neck. So we'll adjust our collar to suit. If we find that it is a little bit too big while we're putting it on, we can always take it back out and change it. So we're going to get an offsider to come through and brace the head for us, hold it nice and still. Right, and poke our Velcro through the bottom there, sit it around about centre. We can see that that collar's probably looking too big, so we'll change it. Bring it back to a regular. And we'll have another crack. From the bottom, pulling the Velcro through, and we'll fold it round nice and gently, keeping the head nice and still. We fold it round over top of the shoulders so it's bracing everything we can. And it comes around nice and tight. And there we go. So it's nice and secure. Obviously on a person we would ask for consent first. Alright, so we're going to go through a bit of fracture management. Amy here is going to be our patient. She's got some pain to her lower arm, so we're going to go through, we'll use the mnemonic plus disc to find out if she's got a fracture. So what would your pain score be at the moment, do you think?
Out of what?
Say 10 being the worst pain in your life and 1 nothing at all.
Probably about an 8.
About an 8? Okay. So adequate pain there. We've exposed her injury. We'll say that it's got a wee bit of swelling, a little bit of deformity as well, so that's adequate enough to point towards a fracture. So we're going to have to splint that, but we'll give you some pain relief to start with. So we'll use methoxyflurane today. We'll use a 3ml ampule. The contraindications to using this, if you've had malignant hypothermia,
No.
family or your personal history. No. So she can obviously obey commands. We're talking to her at the moment. You don't have any known renal impairment, do you?
No.
No, cool. And you haven't received it in the past week?
No.
No? Cool, okay. So it's important to tell our patients to breathe in and out so our charcoal filter can do its job. We can fit an acute mask if you want to the end, keep it secure around the mouth. So if we give this to you now, so while she's taking the pain relief, I'm just going to check for a cap refill. So her cap refill's fine. We've got a pulse. And you can feel me touching your fingers, eh? Yeah, cool. Okay. So that's fine. What would you call your pain scale now?
Probably about a 2.
About a 2?
Yeah.
Okay, cool. So now we can start looking at splinting. Yeah, so we've gone through, we've brought down our pain scale down to a 2, so we're going to have a crack at splinting the limb now. We're going to use a box splint for this. Alicia here is going to give us a hand just to help support the limb while we work the box splint on. But it's important to coach our pain. Okay. So It's important to tell our patients to breathe in and out so our charcoal filter can do its job. We can fit an acute mask if you want to the end, keep it secure around the mouth. So if we give this to you now, I'll just, so while she's taking the pain relief, I'm just going to check for a cap refill. So a cap refill's fine, we've got a pulse, and you can feel me touching your fingers, eh? Yeah, cool. Okay, so that's fine. What do you call your pain scale now?
Probably about a 2.
Go to 2?
Yeah.
Okay, cool. So now we can start looking at splinting. Yeah, so we've gone through, we've brought down our pain scale down to a 2, so we're going to have a crack at splinting the limb now. We're going to use a box splint for this. Alicia here is going to give us a hand just to help support the limb while we work the box splint on. It's important to coach our patients that they can keep using the methoxy as we go through. Nice deep breaths on it, and we'll just support it like that. Lovely. For the purposes of now, we're going to use triangular bandages just to tie it up and support it to the box. So if we can't, and around. Feel comfortable enough?
Yeah.
Sweet. Okay, so we'll just tuck these bits and pieces away. Now we can shift our arm around and lay it back on our lap. Just like that. From here we can go through, we can put a triangle bandage around and swing it. Or she could possibly even carry it out like that if she's happy enough. The last thing we're going to do is check our neurological and cardiovascular responses. So her cap refill's still fine. Just like that, you can still feel me touching your fingers?
Yeah.
So yes. So, yeah, sprinting.
Last one.
Checking changes. Response, hey buddy. Can you hear me? You there? Airway's clear.
No breathing.
Not breathing.
Compressions.
Compressions. Control, you to the left. Pressure is over 49. Can I give it 150?
Begin by removing all clothing from the patient. Place the pad exactly as shown in the picture. Press firmly to the patient's bare skin. No one should touch the patient. Analyze. No one should touch the patient. Analyze. Shock advised. Stay
Clear.
clear of
Everybody out.
patient. Press the flash
Shocking.
shock delivered.
Shock delivered.
Be sure the
Continue
ambulance
compressions.
service has been called. It is safe to touch the patient. Start CPR. For help with CPR, there's the flashing blue light.
Airway in. Airway's in.
One minute, 45 seconds until analysis will resume.
And we're turning the bag mask up to 15 litres a minute.
1 minute,
Bag on
30
the plate,
seconds until
the
analysis
oxygen
will
is
resume.
empty. Right, we'll do a couple of breaths, and then we'll start counting 30. Chest rise, chest rise. I'll count to 30. Keep it up.
1 minute, 15 seconds until analysis will resume.
5, 6, 7, 28, 29, 30.
Chest rise, chest rise.
1 minute until analysis will resume.
5, 6, 7, 28, 29, 30.
Until analysis will resume.
Chest rise, chest rise.
30 seconds until analysis will resume.
5, 4, 3, 2, 1.
Chest rise, chest rise. Lovely. Swap over on this next loop.
15 seconds until analysis will resume.
5, 5, 4, 3, 2, 1.
Chest rise. Chest rise. Swap over.
No one should touch the patient. Analyze. No one should touch the patient. Analyze. Shock not advised.
No shock advised.
It is safe to touch the patient. If needed, start CPR. For help with CPR, press the flashing blue button.
21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Chest rise. Chest rise.
1 minute, 45 seconds until analysis will resume.
26, 27, 28, 29, 30.
1 minute, 30
Chest
seconds
rise.
until analysis will resume.
Chest rise.
1 minute, 15
5,
seconds
26,
until
27,
analysis will
28,
resume.
29, 30.
Chest rise. Chest rise.
1 minute until analysis will resume.
27, 28, 29, 30.
Chest rise. Chest rise.
25 seconds.
Alright, so we'll just go through our physical checks on this defib before we start using it. So in the back here we'll just check our batteries. We're doing that, we'll unclip this and fold that down. In the back here you can see our batteries. To check their charge, just press these buttons. You can see that that battery's got 4 lights and that battery's got 4 lights. So that means that we're fully charged. If you ever want to remove the batteries, it's just a finger in the side there and they lift out nice and easy. So get all that back up. So in this pocket here we have our defib pads and our defib leads, and we have our puck doing our test shocks. We also have the attachment here for our 12 lead when we want to go ahead and do that. So we've got our puck and there's our pads, as you can see. In the back here we have our razors, our GTS spray and our aspirin. It's a good point to go through and check our use by dates on those as we go through. So we'll do that shortly. We have our ECG electrodes. Also in the back here we have our non-invasive blood pressure cuff and we have our spare printer paper. Alright, so that's looking pretty good. In this pocket here we have our ETCO2 for measuring the amount of carbon dioxide in our breath. We also have our SpO2. It's also in there, and we have the attachments for our 3 lead. And we'll just go through and check our printer paper up in the front here. And there's plenty for the purposes of today, that's pretty good. And we'll put all that away. What we're going to go through now is just turn the machine on, and we'll go and put it through a user test. As it charges. We're away, we've gone straight into this mode. So we'll go advisory mode, we'll hit manual mode, okay. Press the select button, and we'll go options, and select user test, select the button on that, and we'll just wait for our test to go through. There we go. And that's come through and said that the user test is passed on the 7th of September. Set that off. Lovely, so now we'll go through and we'll do ourselves a test charge. So in this pocket here, we have our test pack. Go to those, review, set that there. So what we're going to do, because we can't do our test shot on the full 360 joules, we'll bring it back down to 50. To do that, we hit the energy select, and we come down to 50 joules. Hit the select knob, there we go. So we'll charge it. To initiate the shock, hit that, and the shock's now being delivered. In the event that we want to discharge the shock, charge it, and we just press the select. Okay, so we're just going to go through the 3 lead real quick. That's over in this pocket here. I've come pre-electroded for your convenience. Now, we have written on the back of here where they need to be. We have our left lower, right lower, and our left upper and our right upper. So we'll go up here, right upper, left upper, and our left lower, and our right lower. Okay, and now we're going to select lead on here, and we're going to go to the 2, the 1 and the 3, and that's going to bring up our heart rate. Now to change the size of it, we're just going to select that, and we can go down to size there, and we can bring that up to whichever size we like. So we'll leave it on 1 for the purposes of this, and we'll just go back to our home screen. Alright, to change the volume, we're going to select our heart rate, and our QRS volume, we'll just enter into that, and we'll just turn it up. Just like that. So I'm going to bring that back down, and we can leave that on 0. We have our ETCO2 over here in this pocket. What that does is it measures the carbon dioxide in our breath, and that just screws into the side over here, and then we can blow into it, and that will measure that for us. And then we have our SpO2 in here. This measures the amount of oxygen we have in our blood. To use these, we'll just take my glove off. Simply place that on our finger just like that, and we should see it come up over here on the screen here very shortly. And there we go, we have a saturation of 9600, there you go. So SpO2, so that's all pretty healthy. This is pretty good because we're taking that off, and I'll just go through our non-invasive blood pressure cuff. It sits in our back pocket. Throw that on our arm, just like that, with the line there facing down the main vein. Flip them over, and to activate it, we just hit our NIBP button there. Yeah, that's giving me a blood pressure of 169/92. Must be that coffee I had this morning. And that will be my film on our AEDs. Cheers.